Okay, so finally we've sort of got to the end of going through UCAT things, and obviously that's going to come back to haunt you in the summer as you start to really get stuck into doing that. But what I wanted to use most of the rest of the time we've got to try to do is to start to talk about the kind of things you might have to talk about, assuming that your UCAT works out well and you actually get some interviews. Because, of course, the interviews in the end are what determines whether you get offers. UCAT is just the passport to getting an interview. But it's how you perform at the interview that determines whether you get an offer. So we need to do a little bit of sort of preparing for interviews and things like that. And from next week onwards, we'll focus mainly on the sort of individual interactions, because that's what interviews are mostly about. Is, you know, how good are you at talking to, or how good do they think you're going to be at talking to patients and at working collaboratively with your colleagues and at coping with stress and that kind of stuff. But there is a certain amount of sort of background knowledge about healthcare that they expect you to have. And in particular, I think they want you to have some knowledge of the NHS, because it is such a sort of central part of healthcare in this country. So I thought we'd just talk a bit about the NHS today and get you thinking about what's good about it, what's not so good about it, what we might be able to do about it, that kind of thing. So this is the message that you want to put across if they talk to you in any way about the NHS. First of all, I think you need to sound committed to it. So if you happen to be, you know, sort of, you know, big believer in free market economics, and you don't think there ought to be big state structures like the NHS and things like that, and you'd rather we had a sort of American every man for himself kind of system, you just need to keep quiet about that in the interview, because that's not going to go down well. Okay, so you need to be an NHS fan. And for doctors, I mean, most doctors, the overwhelming majority of doctors work mainly or entirely within the NHS in this country. It's a bit different for dentists, where, as you'll be aware if you're thinking about dentistry, that the whole profession is moving gradually away from the NHS and into the private sector. But even so, I think you know, you need to be aware, apart from anything else, that the NHS is subsidising your education at medical or dental school. So I think you need to be a fan of it. Second thing then is a little bit of knowledge of how the NHS works, but that doesn't mean that you need to have detailed knowledge, you know, of the sort of administrative structure of health trusts and all this kind of stuff. Interviews in general are not about probing what you know. They're interested in how you think, and, you know, whether you happen to have spent hours reading interminable, boring stuff about how the administrative structure of the NHS is constructed. It is not going to bother them. So it's only really just, in very general terms, understanding how it's funded and that kind of thing. And then the third thing is, in some ways, the one that they're most likely to ask you about, which is, you know, what are the problems that the NHS is facing? What are the problems it's going to face moving forwards? And they're going to ask you potentially to, you know, make suggestions as to what you think we should do about it. And, you know, they're not going to expect you to suddenly spot the magic solution that's eluded everybody else, you know, and sort out the problem there. But they're just interested in whether you've got interesting thoughts on what the issues are. So that's what we'll sort of talk about a bit this afternoon. So let's start with that then. Again, it's the kind of question they might ask you at an interview. And so, what do we think? Any thoughts? Why is the NHS a good thing? Yeah, it's free healthcare. So, just elaborate on that a little bit. Right. Yeah. No. So I mean, this is the big one. It's this idea that it's free at the point of delivery, largely. Um, less so, much less so in dentistry, but in medicine, that's overwhelmingly the case. And it's interesting to think about what it was like before. And do you generally know how long's the NHS been around? When was it set up? Yeah, so just immediately after the Second World War, when the Labour government came to power there. So it's a fairly long time ago, but not that long ago. So there are plenty of people around who are old enough to remember what it was like before then. And what it was like before then was that if you were poor and you became ill, the question you had to ask was, can I afford to go to the doctor? Can I afford to pay what the doctor's going to charge me? Will I be able to afford the medicines that I'm going to have to pay for that are needed? And for a lot of poor people, the answer was no, I can't afford it. So they would either just put up with it or die from it. And so it really did transform healthcare when the NHS was provided, because people don't have to ask that question. As you say, it's free at the point of delivery, so you go along and you know that you're not going to be out of pocket in paying for whatever needs to be done. But I mean, I guess the reason I sort of picked you up slightly to start with was when you say it's free. So I mean, obviously nothing in life is free. So I mean, you're right, but you get to be careful with the wording there. So where does the money come from? Yeah, so effectively through the taxation system. So you might say, well, okay, so actually we are paying for it, so it isn't any better than just paying for what you need. But why is that not true?
The idea is that the amount you pay is proportional to your income. So you sort of the people that aren't paying tax aren't paying as much tax.
That's right. Yeah. So in other words, the taxation system is structured so that the amount you pay is related to your ability to pay. In other words, to your income, as you say, and therefore it means that the amount you contribute towards funding the NHS is proportional to how much you're earning, and or at least is related to how much you're earning, and therefore is sort of structured in a way that the poor people, although they still have to contribute something, they only are expected to contribute what they can afford, not what the actual cost of their treatment would be. So that's a progressive thing, and that's definitely a good thing, as I say, unless you sort of have a political objection to that, but just keep that quiet for interview purposes. Okay, so that's I think the biggest point. But are there any other things that make the NHS a good thing other than just that sort of the impact it has on the user?
Because it's sort of one of their biggest things. That's it, sort of regardless of background, you can still access the same healthcare as anybody else. I mean, obviously that's ignoring the idea. But in the end, if you sort of keep it within the NHS, everybody can receive the same amount of healthcare.
Yeah, that's really important, that you don't go to the doctor thinking, am I the kind of person that they're going to think is worth treating, sort of thing, because you go and you know that everyone can have the same expectations. So, and again, that wasn't necessarily the case, in the old days, that, if a doctor had racist views, then there wouldn't be much that you could do about the fact that he might be, inclined to spend a lot more time with white patients than with other ones. But that's not allowed in the NHS, and that's really important. So yeah, definitely, that's a good point.
Especially the homeless, where they're under the impression of drugs or taking illnesses chase after drugs. The idea is that if sort of you're homeless, regardless of how ill you are, the preconceived notion is always going to be drugs.
Yeah, no, that's definitely right. So yeah, that's a good thing. So again, it's important that you can do that, that you can think beyond the big point. The big point about the money is what you have to talk about, because that sort of was why it was set up and all that kind of stuff. But if you were to get asked that, the problem is that everyone is going to make that point. I mean, you might make it better, but everyone is going to essentially make that point. So it's if you can think of other things as well that it's going to help you stand out from the crowd. So that's certainly one of them. Are there any other sort of just different issues that spring to mind that the NHS helps with? Yeah, I mean that's right. So I mean I think that's true that in the old days, you know, practices would be available where the doctors felt like setting them up, you know, rather than there being any sort of strategic provision of those things. And so that would mean that in some parts of the country there just wasn't very much, whereas the NHS will ensure that that isn't the case. And the other thing that's sort of related to that, which I think is important, is if you think about the way healthcare is changing, it's becoming increasingly sort of technological. So if you need, for example, you know, an MRI scan to diagnose what's wrong with you, you know, an MRI machine costs of the order of £1 million. So if you just had lots of sort of separate small institutions, most of them would have no chance of affording a bit of kit like that. But by having an organised system, you can make sure that, you know, every city or every region or whatever has access to the big technology, and that's made a big difference. Yeah. Yeah, that's true, or it should be true. The NHS computer system, unfortunately, doesn't always make that. But yeah, absolutely. I think that's certainly what we're moving towards. Yeah, that's true. Yeah.
From what I think it's controlled by democracy. People that kind of can choose.
Yeah, I mean that's right. In the end, it means that it's not someone else just making all the decisions, because if you don't like the decisions they've made about the policies in the health service, you can vote for a government that's going to. So again, it's one of those things which is absolutely true in principle. It's not necessarily, you know, it's kind of a difficult link to make work in practice. But yeah.
Yeah, like going on from the fact that it's government backed, it's always, I mean, ideally, decisions around the NHS are generally going to be in the best interest of the public. And because, I mean, comparative to sort of American healthcare systems, British healthcare systems, especially in America, you see a lot of the time that decisions around healthcare generally made profit margins of private companies. And I think you often see that sort of American governments are quite often sort of fighting with private companies to try and improve healthcare. Because it's government backed, they can make their own decisions to healthcare. And I mean, going from what you said about being able to move between hospitals, if I go to Hereford, they say I need an MRI and they haven't got an MRI machine, you can just get shifted on to Birmingham. You can get moved on between, because it's all one big system, you can get moved on where it needs to be fitted.
Definitely, yeah. Okay, so there are a lot of aspects of things. So this was, this was the list that I made, which I think covered most of those, most things. And then I suppose the other one that's, well, there are a couple of those we didn't quite mention. The sharing good practice thing is kind of important. That, you know, again, in the old days, you know, the doctors, they had to qualify at medical school, and then after that, they did whatever they felt like. So you would get doctors still sort of prescribing the same treatments that they'd learnt 40 years ago in medical school and saying, you know, that was good enough for us then, so it's good enough for you now. And obviously, medicine moves on, and that's not the case. And the NHS makes sure that doesn't happen by making sure that good practice is shared and that doctors are required to keep up with developments and things like that. And the negotiating strength thing is important as well. So the cost of buying pharmaceuticals is enormous. I mean, it's a big chunk of the NHS budget, but it's the amount that's spent is much less than would be spent if every GP practice or every hospital or every chemist shop had to negotiate individually with Glaxo or whatever. Because you can imagine if your local chemist shop sort of says to Glaxo, you know, I think you're charging too much for this drug. I'm only going to pay 60% of what you're asking. Then Glaxo will just laugh and say, well, buy then. Whereas if the NHS says that, I mean, they can't do that because it's too big a player and they have to take them seriously. And that's, I mean, they always keep secret the prices that they actually negotiate, but supposedly that, you know, it's often a fraction of what the sort of list price of drugs is. So that's an important thing as well. Okay, so lots of good things, and that's something good to be able to talk about. You sort of mentioned private healthcare, and I just wanted to make the point. Obviously, private healthcare does exist in this country, but it's not still a big player, and it's increasing slowly as I mean, partly as sort of there's more dissatisfaction with the health service, and partly just because they've become sort of more aggressive at marketing themselves and things, that the private healthcare providers. But it's still a tiny thing. So as those numbers are saying, if you have an accident or you have a heart attack or whatever, your chance of being treated privately for the first acute treatment is tiny. Only sort of 3% of those things. Once the immediate crisis has passed and decisions can be made about what treatment you move on to, then some more people go out and have it done privately, but it's still less than 10%. So the NHS is definitely the thing that you have to mainly think about here. Dentistry is a very different story, so we won't talk a lot about this. I will send some information out to the dentists because you need to have quite a lot of understanding of this, but I'll just mention this very briefly because I think everyone ought to know a little bit about this. So when the NHS was set up, it was meant to be the same story for dentistry, that it would all just be covered at the point of delivery, and that actually made almost a bigger immediate difference than the medical care did, because I think I saw a thing somewhere that said that in the 1930s, so before the NHS, something like 80% of people lost all their teeth by the time they were 30 because there was just no free or affordable dental care at all. And so when it suddenly became available free, it was incredibly popular, and huge numbers of people were wanting access to the dentist, and it was just unmanageable. And unfortunately, they reacted by starting to introduce charges to cut down the number of people, which kind of went against the whole principle of the thing, but there you go. And it sort of spiraled a bit from there. But the problem was that the way they have dealt with the dentists in terms of coming up with a procedure to remunerate them for the work they do has never really worked properly, and the dentist got completely fed up with the whole thing in the end and sort of said, that we're doing far more work than you're paying us for, and your incentives that you give us are incentivizing us to provide treatments that we don't think are the best treatments. So it's actually making the healthcare worse. And so gradually they started moving away from the NHS, and it's now become pretty catastrophic. So you can see some of those numbers there. So more than half of dental treatment in this country is now not on the NHS. And lots of people who want it, because obviously it's cheaper when it is on the NHS, just can't get it because dentists are not taking NHS patients. And for a while they just said, well, we won't take new adult patients, but we'll keep treating children. But now lots of them won't even treat children on the NHS. So it's a real mess. And the problem is that it always comes down to money, that it will take a huge amount of money to make it right. And it's not clear whether any government's going to be in a position to do that. So if you're a dentist, you need to know a lot more about that. But for other people, I think it's just worth having that general awareness that there's a big issue there. Okay, so one of the things you very commonly hear, in the media and possibly amongst people you talk to, is people moaning about the NHS. So that being the case, do you think, just from your own experience, that most people are still supportive of it, or are people sort of saying, "Oh, we ought to have a better system like they do in, name a country"?
I think they support the concept, but I don't think they support sort of the current institution. I think the idea of free healthcare they love, but I think the current way it's run, they hate. I think especially with the way that sort of quality of healthcare is at the minute, people really, really want to change. I don't think they really know what they want. They just know that what they have at the minute
is not what they want. Yeah.
They love to complain, but they don't really know. They don't have an idea of what they like.
Okay. Is that what most people think, that the general support for it, or does anybody notice that there are more people sort of saying, "Oh, we should just scrap it and start again"? Okay, I mean, I think that's right. I think that is the case, and this was a fairly recent survey, this was 2023, I think, which shows that I think the sort of national picture is essentially, as you said, that 70% of people agree that the NHS should be free of charge when you need to use it. So that is supportive of that sort of core concept of it. But you can also see that the thinking behind that wasn't altogether joined up, because then when they then asked, should that be available to everyone, then only 67% agreed with that. So there's quite a lot of people who think, yeah, the NHS ought to be free for me, but not necessarily for everyone else. And then, the question is, well, where's the money going to come from? And the answer, as we know, is taxation. But less than half of the people were in favour of that. But if you ask them, well, where else is the money going to come from, you can bet they wouldn't have an answer. So this is the problem with democracy, that it's a wonderful system, but it's also terrible, because it relies on people having a coherent set of views, and most of us don't have a coherent set of views on things. So there is a problem there, that yes, we want it, but we don't like paying for it, is what it comes down to. So we just have very quickly look at some systems in other countries. And again, this is not to suggest that you need to know this kind of thing. It's just that I think if you're going to talk confidently about what's good and what's bad about the NHS, it's just useful to know a little bit about what alternatives could be. So there are a few countries that have the same kind of system as us, like Italy, Spain, and so on. But it's actually quite rare. What's much more common in Europe, at least, is what they call social insurance, which means that they have health insurance system, which means that instead of paying money to the government, you pay money to an insurance company. And then when you need healthcare, the insurance company coughs up and pays for it. But social insurance means that, first of all, it's compulsory. So it's not like the United States where it's just up to you what cover you have. You have to pay an amount that's related to your income. So in practice, it's actually really pretty similar to the system we have here. It's just that you have the insurance companies acting as a middleman instead of just going through the government. But in practice, it's not actually all that different. The USA is the real outlier here, because they just don't have a national healthcare system of any kind. So it is very much a case of every man for himself, and people are told, well, you just have to fund your healthcare, and best way to do that is take out insurance, but it's up to you how much insurance you take out. But up to you largely means it's how much you can afford, and so for poor people this is a big problem. And they have periodically tried to introduce sort of safety nets to make sure that the poorest people can still get basic health care without worrying about it. And Barack Obama particularly tried quite hard to bolster that system, but Trump is now busy demolishing it again, so not good. So the question is, does it work? If you look at the way our system works, you can compare various things, and generally the message is quite positive. So this looks at out-of-pocket expenses. So this means after you've taken away the contribution that everyone has to make that's related to their income, how much money do people actually end up spending out of their own pockets to cover their healthcare needs? And you can see that the UK is the dark coloured bar, almost right at the right-hand side. So the amount that we end up spending on those extra expenses beyond what's covered by the NHS is really quite small compared to in most other countries. So in that sense, the NHS is doing what it was set up to do quite successfully, and making sure that the overwhelming majority of our healthcare needs are met through a system which is funded in a progressive way like that. And this is perhaps the most interesting exemplification of that. So I'm not quite sure how they defined catastrophic healthcare costs, but it's basically meaning that obviously if you didn't have a system like the NHS, you could well be faced with a situation where the costs of treating your illness might mean that it's going to take away all your savings, or mean that you have to move house to fund it, or something like this. I mean, that's the kind of thing that the NHS is supposed to prevent from happening. And you can see it does it really successfully, because we're the fourth one from the left there. In other words, only a very tiny number of households end up with really big money problems resulting from healthcare costs, whereas in some other countries, it's 10 times that fraction. So again, the NHS is doing quite a good job at achieving what it was set up to achieve, and it's important to remember that, because once you start focusing on the problems, they are real and they are serious. But it's important to remember that it isn't that it just is failing, because it isn't. It's doing largely what it was set up to do. Okay, so let's have a look at the challenges a little bit. So this kind of complicated graph is looking at people's perception of how good a job the NHS is doing, so how satisfied they are. So if you just focus on the purple line, which is the fraction of people who say that they're very or quite satisfied with what the health service is doing, and this has just been measured over a period of years there. And it's quite interesting because it's not as flat as you might think. I mean, you might imagine that people have always had the same kind of grumbles, and that the satisfaction would probably sort of bubble along at around the same level. But you can see that's really not true. So it was kind of flatlining at around the sort of 40% level through the 80s and 90s. And then sort of from around 2000 onwards, it started to rise and reached that peak level at over 60%. So in other words, there was a more than 50% increase in the number of people who said, yes, I'm satisfied during that period. And then in the last few years, it's been plummeting. So just with your knowledge of history, anybody got any thoughts as to why there have been these changes?
Big spike in dissatisfaction.
Yeah, I mean that's when it's really plummeted. So it was sort of starting to drop a bit, but yes, it was. I mean, it's quite interesting that if you look from about 2015 onwards, it's starting to drop, and then it actually goes up during COVID, because obviously people felt very supportive of the NHS then. But since then, it's really plummeted. So it's we haven't recovered well from COVID, and it's quite difficult to understand exactly why that is. But we'll talk a little bit about that. So yeah, that precipitous drop at the end is definitely that somehow. And people argue about whether that's really anything to do with COVID or whether it was kind of coming anyway. But there's been a big drop since then. The reason I show this is not so much that I wanted to make a political point, but I mean this has to do with the amount of money that governments were prepared to spend. And I think it's important because quite often you hear the argument, oh, there's no point spending anymore because they'll just waste it. It won't make any difference anyway. And what this graph actually shows is that that's not true, because what's happening here is that the government through the 80s and most of the 90s is the Thatcher government. And she was not, I mean, she didn't want to destroy the NHS. We shouldn't overstate this. I mean, she was in favour of maintaining it, but she wasn't in the business of spending public money on anything she could avoid spending it on, and that included trying to make it any better. And that was why it just sort of flatlined. That they kept it going, but they didn't try and improve it. And that big rise in satisfaction in the early 2000s is because that was when Tony Blair and Gordon Brown came along and decided that they would inject a lot more money into the NHS. And the way they did that has been controversial in various ways, but it did at the time at least mean that lots of new hospitals were being built. There was much better provision of equipment and this kind of stuff, and there were more people employed as well. And so it did make a difference, and that was reflected in the satisfaction levels. And then it starts going wrong, although the effect is only quite slow, but it starts going wrong sort of in around 2009, because what happened in 2009? Yeah, so since then, the idea of injecting lots of extra money for anything has been kind of difficult because there just isn't much money around. But I think it's interesting, and it's not, as I say, because I wanted to make a political point particularly, but it's because I think the idea of saying, oh, it's not to do with money, you can't get away from the fact that it is to do with money, and that if we can find ways to find more of it, and so long as we figure out what it really needs spending on, then that probably is what can make the difference. Okay, so what are the causes of dissatisfaction? So when people grumble about the way the NHS works, what do they grumble about? Yeah, that's the big one, isn't it? It's the waiting times, the amount of time you have to wait to get a GP appointment, the amount of time you have to wait to get your surgery done if it's non-urgent, and waiting times in A&E, all of those kind of things. That's the big one. And so if you look at reasons for dissatisfaction from actual surveys that have been done, that's the big one at the top. It takes too long to get appointments. The second one says not enough NHS staff, but actually that's probably really the same complaint, and people are just assuming that that's because there aren't enough doctors and nurses. But as we'll see, it may not be quite as simple as that. And the third one as well, government doesn't spend enough money. So probably the main reason that they're saying that is because they're thinking, well, if there was more money, we wouldn't have to wait so long. So that's overwhelmingly the main thing. There obviously are other things, quality of care, people sort of saying, well, that they aren't as well trained as they should be, or there isn't good enough equipment, that kind of stuff, and attitudes and behaviour. But these are small things in comparison. So it's the waiting times that we mainly need to talk about. So the obvious question is, well, should we spend more? So we looked at that graph which suggested that if you spend more, satisfaction levels go up. So that suggests that maybe we should. But it's easier said than done. So well, we won't spend too long on this. This is just showing that if you compare us with other countries, so we're the purple bar there, we're not actually particularly mean. We actually spend more than the average of developed countries on our healthcare. And most people spend in the sort of countries comparable to us, a roughly similar amount. The real outlier on that chart is the United States, which is kind of interesting because they spend getting on for double what most other developed countries spend in terms of the proportion of their sort of national wealth they spend on healthcare. So does that mean that the average sort of health of Americans is much better than the average health of? No, absolutely not. And if you look, for example, at life expectancy, the USA has a lower life expectancy significantly than almost any European country. So it's the fact that they have a catastrophically bad system and it just costs a lot rather than that they have a really good but expensive system. We'll skip that one, but this is the interesting one. So as I say, the evidence is if we spend more on it, it gets better, so long as we spend it wisely. But if you then ask people, so okay, are you willing to agree to having a tax rise in order to make that happen? You find that the majority say no. And it varies a bit between income groups, which is what this is showing. So the people on the lowest incomes, it's only a very small majority who are not in favour of tax rises. But as you go to higher incomes, it's slightly counterintuitive because you might think, well, if people have got more money, they might be more willing to spend some of it on the NHS. But actually, the highest paid have the lowest enthusiasm for paying more tax. But of course, that's because they're paying much more in actual terms, and therefore they're saying, well, I'm going to be paying hugely more, not just a few pounds more. And also, of course, they're also the people who have access to private healthcare. But anyway, that doesn't really matter. What matters is that people are not big fans of paying more tax. So you might think, well, okay, the government just has to be tough and point out to people, well, we know you're not going to like it, but it's the only way the NHS is going to get better. So we're going to impose a, 2% in the pound, 2 pence in the pound increase in taxation to make it work better. So why don't they do that? Because they all know that's what they probably should do if they're going to make the NHS any better. But why don't they? Yeah. Yeah, so next election, what happens to your number of seats? Yeah. I mean, that's the trouble. You're just going to get voted out of office. So they can't ignore this kind of thing. And, that it is the problem that, democracy is wonderful because it means we all have an influence on what decisions are made. But the trouble is that a lot of the time you don't get a coherent policy as a result of what the public thinks, because it's not our job individually to have a coherent policy, so we don't bother having one, and therefore it's difficult for the government to respond to what the public wants and do something that works coherently. So what that means is, if you get in your interview and are asked what should be done to improve the NHS, you can't just say spend more money, because they're going to think that sounds impossibly naive. They're going to at least expect you to discuss why that's a hard thing to do. And I mean, going back to that Blair Brown thing, I mean, they built loads of new hospitals, but they did it in ways that were kind of dodgy. So they had these things called private-public partnerships, where a lot of the money was provided up front by private companies, sort of working, and the NHS would then have contracts in them to sort of lease back the hospitals that were built. But this leads to consequences where, to the present day, some of these companies will charge £50 to change a light bulb in a hospital because of the terms of these deals and things. So, it was a bold initiative, but it wasn't all good. So let's look at an example then of one of the problems that people, that's quite serious, which is the waiting times in A&E. And so let's look at the data first of all. So this is one way of quantifying the problem, which is to say, well, how often is it that people have to spend more than 4 hours before they get treated in A&E? And you can see, if you go back to 2012, it was really quite rare. It was only around 5% of the patients who would have to wait that long. And by last year, that was up to about 45%. So, it's a sort of 9 times higher probability, roughly. So that's an enormous change. So you can see why people moan about it, because it's not a sort of marginal change. It's a whole complete sort of sea change in things. And it's been a steady rise since then, except what's the blip in sort of 2/3 of the way across? Yeah, so that's COVID. And obviously what happened during COVID is that the pressures in A&E were massively reduced because people weren't going out, so they didn't have accidents so often. And they were also very keen to stay away from hospitals. So again, they wouldn't go unless they really had to. And post-COVID, it continued to rise actually very steeply, but things have been done to try and deal with it. And so it's at least halted the rise, but it's not falling very quickly, as you can see from that. So it's still a huge problem. So what's causing it? Okay, so why do you think there's been that enormous increase in typical waiting times in A&E? Okay, so that would be a possibility, wouldn't it? That there just aren't enough doctors and nurses, so people are waiting around because there aren't enough staff there to deal with them. Okay, so that's one possibility. We'll look at all the evidence for all of these in a minute, but let's get some other ideas first. Yeah, so when you go to A&E, they always have these little posters up about, if you've got this, this, and this, you shouldn't be here. Please go away, sort of thing.
Yeah, and a lot of the time they'll say, there's a lot more. Compared to like 20 years ago, there's a lot more serious things that are actually good. They actually do it to pharmacists, because at the end of the day, they haven't got the facilities to accommodate all of they'd rather you went somewhere else to sort of you off.
Yes, I mean, I think that's true. So I mean, there's definitely an issue there, and of course, a lot of people go to A&E who in the past would have gone to the GP because, 10 years ago, if you phoned the GP, they would probably say, "Oh, come round this evening," and now they'll say, "Come round a week next Thursday." And so it's those waiting times for the GPs that are sort of pushing people to go to A&E because they see it as an alternative. So yeah, that's definitely a factor. Any other thoughts? Okay, well, let's have a look at some of the evidence and then see what the big issues really are. So this is the number of people attending. So we've sort of hypothesized that maybe there's been an increase in the number of people attending A&E who really shouldn't. And you can see there has been an increase in the number of people going. So it was around sort of 38,000 or so in 2011, and it's sort of around 42,000 now. So, there's been maybe a sort of 10% increase in the number of people attending. And that may be partly, as you say, because they're going there rather than places they could more appropriately go, like the GPs and so on. Why else might it be that there are just more people attending altogether? Yeah, the population is increasing. And so we need to think about that. So let's have a look at the population. So this is over this makes it look dramatic, but this is over a much longer time scale. So just looking at the right-hand end, between about 2011, the population was about 63 million, and it's now probably about 68 million. So it's risen by a significant amount, but considerably less than 10%. So that could account for a big chunk of that 10% increase that we saw on the number of people attempting, just that there are that more people in the country. But it doesn't account for that dramatic increase in waiting times because that's too small in effect. But it is interesting then that you can't ignore the fact that the population is going up. And there's something else that we perhaps ought to think about, which goes beyond just looking at the total number in the population. But what about the composition of that population? What might be changing there that would have an impact on A&E? Yeah, so that's quite a big factor, and probably more of a factor when we're looking over a longer period of time. But there has been a huge change in the sort of demographic distribution of the population, and this is quite a nice picture that shows that. So you've got 3 times here, 1966 and 2016, and then a projection for what it might be like in 2066. And the idea here is that age is on the axis running up the side there. So it's going from age 0 to 100. And the width of the bar at each year is basically the fraction of the population that's in that age group. And you can see in 1966 that the biggest population of the age group were the really young children. And there are some, dips and bumps beyond that, but essentially that gradually decreases. And then once you get to the age of about 60, it wasn't looking good because the population then, you can see the bars narrow really steeply above 60, which means once you reach that age, your chance of dying off in any given year was becoming really quite significant, which, at age 65, I have to say is not a good thought, really. But the good news is by 2016, that's got a lot better. So you can see that the young children are no longer the biggest group, and that's partly, well, what is the reason? Why do we think that might be? Is that a huge effect? I don't think. I mean, there is an issue there, but I don't think that's a huge one. But I think it's not so much infertility as just people deciding to have smaller families, I suspect.
Yeah. Also, I think social. If anything, the increase in mortality rates, that's like
Yeah,
Yeah,
because
but years and years ago, if popularity was that you charge people to die,
you'd have lots of them to
Yeah.
yeah. I mean that's sort of sad but true. So I mean it's partly down to that, but it's also of course it's just that healthcare has got better, so we've kept more people alive in the older age groups. So it's not just that the number of small children has decreased; it's that the number of older people has increased. So as a proportion of the population, um, that they've increased significantly, and you can see that's made a huge difference in that sort of 50 to 70 age group. Once you get much above 70, it's again starts to narrow. But you've got a longer period where you think I've got a reasonable chance of staying alive this year, and by 2066, that's really quite dramatic, and we're going to have a much bigger population of people who are old. But the trouble with these statistics is they just tell you whether the people are alive or not. They don't tell you how healthy those people are. And the reality, of course, as we know, is that lots of people who are in their 70s, 80s, 90s, although they're happy to be here where they might not have been, 50 years ago, they're still not necessarily having a particularly good time because they're much more prone to illnesses which might well need treatment in A&E. So you've got a much higher risk of, heart problems or things that feel like they could be heart problems. So you ought to go to get them investigated. And they have more accidents, fall over more often, and when they fall over, they're more likely to suffer consequences that need treatment. So an aging population is a big factor, but it's not changing quickly enough that could explain what's happened in the last 10 or 15 years. But it is a factor in the sort of bigger picture over a longer time. So again, when you're thinking ahead to interviews, and if you get asked, what are the big problems that the NHS is going to face in the future, you can talk about money, but you could talk about an aging population. That there's going to be this challenge that they're going to be. Our success at keeping people alive is great, except that it's going to give us a whole lot more work in terms of the number of people who are going to need medical interventions. So somebody mentioned staff shortages, so let's just investigate that one little bit. And what this shows is that it is true that we are very sort of under-doctored compared to most European countries. So England is the light blue band there, and so it shows that the number of doctors per 1,000 inhabitants is small compared to lots of other European countries. So that would seem to be some evidence that says maybe some of our problems come from the fact that there just aren't enough doctors. But this is a really interesting picture. So again, it's very complicated because there's lots of different data on here, but the black line is the number of doctors that have been in the NHS from 2009 to well, nearly the present day. And you can see that contrary to what most people in the public would think, the number of doctors has not decreased. It's increased, and not just a bit, but by nearly 40% in that period. So in that period where the A&E waiting times have gone up so catastrophically, the number of doctors in A&E, because that's broadly in line with the overall number, which is what you can see there, has actually increased a lot, which is quite interesting. And what it says is that just increasing the number of doctors, and some of the other lines there are other people, like nurses of the sort of turquoise line. You can see they all follow the same kind of trend. It doesn't actually help in terms of improving the waiting times and things like that. The interesting thing there again is that remember 2009 was the financial crash, so after that everybody was having to try and make savings, and you could see that they largely thought, well, we can't really start cutting doctors and nurses because quite apart from whether that was a good thing to do or not politically, that would have been unacceptable. So who did they cut? Who do you think the purple line at the bottom is? Yeah, okay. So in other words, they thought, okay, well, we'll just cut the people who mend the holes in the roof and stuff like that. But you can only do that for so long before you have too many holes in the roof. So they've sort of eventually realised they had to reverse that policy. But yeah, it's interesting. But that's really important. Okay, it says that just increasing the staff doesn't seem to help. Um, and this is just another way of looking at that same point. So this is over actually even a more recent time. So this is sort of just before COVID compared to now. And you can see the staffing levels across doctors, nurses, and support staff. They've all increased in the region of 20%, but the productivity, the number of treatments delivered, has basically not changed. So that's really damning. How can we be employing all those extra people and yet we're not delivering more treatment than we used to? So if we're deciding to, if you got asked in an interview, if I gave you lots of money to get rid of the A&E waiting time problem, and you said employ more doctors and nurses, that would seem entirely reasonable. But what this says is that's pointless because it's not actually achieving anything. So why not? Have you got any thoughts? Why have all these extra doctors and nurses not actually improved the waiting times? Yeah. No, because this is actually the number of people employed, not the number of people who have trained. You see what I mean? So this is the number of people actually working. But you are kind of right, though, that just counting the number is a bit dodgy, because if they're all, as you say, very junior and the number of senior ones have decreased, that would cause a problem. And maybe some of that. And also, what not so much in hospitals, but in GPs, what's caused the huge problem is because the total number of people working as GPs isn't actually significantly. I mean, I think it's actually higher than it was 10 years ago. But what's changed with GPs particularly? Because there are more of them, but it's harder to see them. And why might that be? Because loads of them work part-time, and that's really changed. That they used to all basically work all of the time, and then when they sort of government changed the deal with them, they decided that actually they could quite comfortably maintain their standard of living working part-time. So lots of them do, and that's part of the reason why there's a big GP problem. And it also means that the senior ones, who are probably the best at it, are spending the less time doing it, and a lot of the people are the junior ones who are less effective, which is also a problem. So yeah, I mean, so there is an issue there that these are, it's always dangerous just counting the overall numbers. You need to break it down a bit. So I don't think that's a huge factor, but that's a good thing to point out, that it's an oversimplistic thing to look at.
We've got more staff, but not necessarily more equipment. Staff aren't doing the work that they have.
Yeah, and absolutely. And by equipment, we're not necessarily talking MRI scanners or something like that. We're talking beds and things like that. So actually, if you spend time in A&E, you quite often see junior doctors standing around, looking like they're not got anything useful to do, and you think, well, that's not very impressive. Why don't they just get on and see more patients quickly? But the answer is because there's nowhere to do it, because all of the cubicles are filled up. And so that's the thing, that if you're going to spend money, you have to do your research and figure out where the bottlenecks are, what causes the problem. And I think you're right. It's not the numbers of staff so much as the space and the equipment that they need to actually do their job, that there just isn't enough of that. So people are waiting around for that to become available. So obviously one way to deal with that problem would be to build more hospitals or expand the size of the existing hospitals to make more beds available in A&E. And that would undoubtedly have an impact, but it might not actually be the most effective way of doing it, because what we need to do is to think about why are, if that's the reason, why are these treatment rooms all filled up all the time where they weren't 15 years ago? So what might be the reason for that? And I think sometimes it is because medicine's become more technological, so there are more tests that can be done and this kind of stuff. So they're spending more time waiting for those. But that's actually not the biggest thing. Because if you think about when you go into A&E, basically three things are going to happen. One possibility is that you die, but hopefully that's not going to happen. The second possibility is that they sort you out and they send you home. But actually the third and the biggest of all of the three is what? Yeah, you have to go to a different department, and what's the problem then? Yeah, the departments are full. So what doctors and admin staff in A&E spend most of their lives doing is frantically speaking on the phone, trying to find a space on a ward to get someone onto who they need to refer for further treatment. And that's the big problem. So if we have a look at, skip this, yeah, this one. So this is a graph that shows you the number of patients waiting more than 4 hours, which is the blue line, or more than 12 hours to move on from A&E to another ward in the hospital. And you can see this is the thing that has risen out of all recognition in the last 15 years or so. So the blue line says that in 2011 there were only around maybe 10,000 patients who had to wait more than 4 hours to be moved on from A&E to another department, whereas that's gone up from 10,000 to something like 160, 170,000. That's an enormous increase in the number of people waiting around. And, prior to COVID, it was almost unheard of for people to have to wait more than 12 hours to move on, but now that's become a real thing. And, around 50,000 people per year in 2023 were just sitting around. They'd had their initial diagnosis, they'd had whatever initial treatment they could have, but they needed more and they couldn't get it because they were stuck in A&E. And some of them, if they weren't, all that critical, they might have been sent to sit back in the seats in the waiting area while that was sorted out. But of course, a lot of them would still need monitoring. If they had potential heart conditions and things like that, they couldn't say, "Well, just go and sit down." They need to be continually monitored. So they're then blocking treatment beds, and that's the big problem. So, but why? I mean, again, it comes down to why is that a problem now where it wasn't a problem 15 years ago? So what do we think? In other words, why are the wards so full? Why do they not have the spaces that they used to have? Again, you need to do the same kind of thinking, really, which is if you go onto a ward, you're hopefully not going to be there for the rest of your life. At some point, you're going to be sent home. But what does the medical team have to be sure of before they can send you home? Yeah, so that's partly about have they done all the medical treatment they can. But after that, it's about can you go home and function properly in a safe way? And obviously, if you're sort of largely young and healthy and you just had a specific ailment which has now been dealt with, then the answer is yeah, probably we can just send you on the bus and you'll be fine. But if you're 97 and you've had a fall, they can't just send you home and say you'll be fine because you won't.
Also improved medical service because there's the capability to care for them better, and because standards mean that you have to, it's more difficult to doctor people, you have to look after them.
Yes, I mean, I think that's right, but I think it's largely the aspect of who's going to look after them when they get home if they can't look after themselves. So that means either you've got to get them into a care home, or because most of them will want to go home to their own homes, they'll need to be care workers coming in to make sure they get up in the morning and get fed and get washed and this kind of stuff. And what's the problem there? Well, yes, it would do if we did what needs doing, which is to increase funding. Because the problem with the care system is that care workers are atrociously badly paid, and it's a hard job. I mean, it's not a particularly pleasant job. Well, it depends on the people you're looking after, I suppose, but physically it's demanding and it's badly paid, so it's just really hard to recruit enough care workers. Yeah, because they just can't release them. If they say, well, I'm not convinced you're going to be safe, then they just end up blocking the beds in the hospital. So, what we've come around to is that probably the single best thing you could do if you were trying, if your starting point was how do we deal with the waiting times in A&E, then you have to really think outside the box and think what we should do is have more money spent on care workers in the community, and if the whole system working from one stage to the next would then function better, and A&E would work better as a result, but so would all these other things. So all these people blocking beds in hospital, it's not because they want to be in hospital, it's because they can't leave, so they would be more than happy to be released if there was going to be enough support for them. So my point in going through all of this is not that you need to go away and memorize all of this and be able to churn it out if asked in an interview, because they won't ask you in interviews to demonstrate your knowledge, but it's just showing you that you have to be able to think quite creatively and not just give the most obvious answers, but sort of say, this could be a factor as well, and this could be a factor as well. And even if, what the experience this afternoon was that you had lots of really good suggestions actually, and sometimes they turned out to be minor factors and sometimes they turned out to be big factors, but they're just going to give you credit for the fact that you thought about it at all. And that's the important thing. So it's having the confidence to think about the fact that the provision of healthcare is a hugely complicated thing, and showing that you have to think about lots of stuff and not just the most obvious things is what's going to impress them. Okay, so we'll I think we'll sort of leave it there for this afternoon, because I think this just goes on to make more of the same points. And as I say, this is a bit different from what we'll do in most of these sessions, because this is about your awareness of the system, but most of what you'll get in the interview is going to be focused on you, and it's about your opportunity to convince them that you're going to be someone who's good at dealing with patients and good at dealing with your colleagues and good at dealing with the stresses of the job. And so we'll talk about how to learn to talk about things in a way that will achieve that. Okay, so that's where we'll go next week.